Hi, and welcome to Unit 4. And this PowerPoint goes over one aspect of Unit 4, and that is heart attacks or acute coronary syndrome. And let's talk a little bit more about this condition. So what develops is atherosclerosis. It is the formation of plaque within the arterial wall, and that is the leading cause of cardiovascular disease. This plaque is a combination of platelets and fat that accumulate, and it causes narrowing of the artery. So typically, if someone has high cholesterol, we will place them on a medication as well as make some dietary recommendations. A common medication that we're going to use are statin drugs like atorvastatin, simvastatin. And just to remind you guys back from pharm, one of the big things we want patients to report when they're on a statin medication is myalgia, muscle aches and pains, because this could be a symptom of an adverse effect called rhabdomyolysis, and that's where the muscles actually start to break down. And some other considerations for statin medications is that we want to check liver function tests, so your ALT and your AST, because the liver does a lot of the processing with these statin meds, and that can cause liver damage over time. And we also want patients on statins to get annual eye exams because they carry the risk of cataract formation. So, if they have that muscle soreness, though, that needs to be reported to the healthcare provider immediately. Um, and if your patient has any sort of liver problems, liver disorders, cirrhosis, whatever, we want to question whether a statin medication is appropriate for the patient. So, getting back to atherosclerosis and cardiovascular disease, there are some risk factors. Some of them are modifiable, some of them we can't do anything about it. Modifiable ones, we can control them to a certain extent. So we want to, adequately treat hypertension. We want people to reduce their weight using healthy methods. Um, we want to encourage them to stop smoking, but this is also meaning we aren't going to judge people if they aren't able to make these modifiable changes. Just always use a positive approach because sometimes these changes are very difficult to implement. Um, so they want to stop smoking, they're having some difficulty, they can use a nicotine patch, but we need to give them education. If you remember back from um, pharmacology, we don't want people to smoke because there is an increased risk for heart attack or stroke if they do that. With any sort of patch, we want to make sure they remove the old one prior to putting a new one on, and they don't want to put the patch in the same spot every time. So for hypertension and or cardiovascular disease, we're going to give them a heart healthy diet. That's usually a low cholesterol, low sodium diet. Usually a good sodium intake goal is 2 to 3 grams per day. And a no-brainer thing they can cut out is a lot of canned food or highly processed food because they tend to be high in sodium content. People that have diabetes are 2 to 4 times more likely to have heart disease, and they can actually have what's called a silent heart attack, so a heart attack without the symptoms. Then we can have family history. So obviously, we can't control our family history. Um, we can't control our age. A non-modifiable risk factor is advanced age as well. Um, so look in your textbook. It'll give you even more examples, but I wanted to just highlight some of those modifiable risk factors and how nursing plays a role. Um, so just another big thing to highlight is hypertension. It's something that we've talked about on a discussion board by this point in the term, and it's really something we need to put together with how we can compromise other organs. So you can have renal impairment, you can develop heart failure and be at increased risk for stroke um, with hypertension, and it also puts you at a higher risk for a heart attack. So, linking how the blood flows and the effects of high pressure and low pressure on those organs is important because with hypertension, it's high pressure, which is really hard on the blood vessels. And you can also have the opposite problem. You can have very low blood pressure, and then you risk low perfusion as well. So we want to make sure that the kidneys are something that is on the top of our mindset when we're looking for um, consequences of cardiovascular disease, hypertension. And the ideal urine output is 1 milliliter per kilogram per hour. Um, and so leading forward, we talked atherosclerosis, we talked risk factors. Let's talk what is coronary artery disease. Basically, it's that atherosclerotic changes, cholesterol, calcium deposits, fat deposits um, on the causing plaques, which causes a narrowing and then reduced blood flow. And that's what this picture is showing you, a nice open artery versus one that has that plaque formation. With a heart attack or an MI, myocardial infarction, what happens is that plaque has built up and it can actually rupture and then a blood clot can form, or the atherosclerosis can actually completely occlude a blood vessel. And so when we have that occlusion um, and that decreased perfusion, that is a heart attack. And what we're dealing with is ischemia, so decreased blood flow to the myocardial tissue. Um, what are the factors dealing with the severity of a heart attack? Well, it depends on where the blockage is located, how long that blood flow has been blocked, and the amount of damage that has occurred. So the higher up in the coronary arteries, the larger area is going to be affected. And a lot of times we can see that effect on an EKG. And remember, EKGs are the map of the electrical conduction of the heart. And so there are things that we have to kind of figure out what's going on. If your patient has symptoms of, oh my gosh, they've got chest pain, it's going down that left arm. Okay, well, what's going on? Is it angina? Is it a heart attack? And if it's a heart attack, is it a STEMI or a non-STEMI? So, first of all, let's talk unstable angina. Stable angina is predictable chest pain from a person that's been diagnosed with coronary artery disease, and that pain is relieved with rest or with nitrates. And the symptoms are predictable and they stop predictably. When it becomes unstable is when it's not relieved by nitrates or rest, or it becomes unpredictable. Maybe you start having it at rest and it gets really bad with activity versus before you knew you would get it with activity. So an example of stable angina would be chest discomfort that occurs when someone is mowing their lawn, and then if they stop and take a break, it goes away. And so going from stable to unstable, that angina starts to occur at rest and or it starts occurring for longer period of time or causing more severe pain. And then there's a STEMI versus a non-STEMI. And we're going to talk about this in a further slide. But just to kind of plant that information in your brain, basically a STEMI means ST elevation myocardial infarction. So we've learned how to read EKGs at this point in the term. So now, remember I told you that we look for the ST segment. If it's elevated, it's supposed to be on the baseline. It's supposed to be on that isometric line. If it's elevated off of that, that's a STEMI. A non-STEMI means that elevation doesn't occur. Okay? So that's just in a nutshell what those two different terms mean. And I will talk about STEMI versus non-STEMI in another section. So after you've had a heart attack, you've got an area of infarction, injury, and ischemia. And what each of those means is listed on this slide. So coronary artery disease is the most common form of heart disease, and it's also the most common cause of heart failure. So, like I said, with atherosclerosis, over time, the arteries that supply blood to your heart muscle build up those fatty deposits, and those deposits reduce blood flow. So, the heart attack happens with those plaques rupture and allow a clot to form, which can block flow to blood flow to an area of the heart muscle, and that weakens the heart's pumping ability and can leave permanent damage. If the damage is significant, it can lead to a weakened heart muscle and decreased cardiac output, specifically if it affects the left ventricle, which is our major pumping chamber. So the left side of our heart is the worst side to have an injury because injury to that side is going to reduce your cardiac output. Reduced cardiac output can also increase the risk of heart failure. Heart failure can affect the left or the right side, and generally it begins with the left side because that's the heart's main pumping chamber. So this is just a description of how the levels of injury occur and ischemia versus infarction. So, like I said, I would talk about the types of acute coronary syndromes, and that's what I am talking about on this slide. So remember that angina is a periodic ischemia that is due to the narrowing of the coronary arteries. So that causes an imbalance between oxygen demand and delivery of that oxygen through blood flow. With just regular, plain old, stable angina, your troponins are going to be negative. And remember, we talked about troponins being the most sensitive lavatory value to look at to see if there is some sort of cardiac damage. The same process that causes angina but progresses through unstable angina to a non-STEMI to a STEMI. So remember with unstable angina, that narrowed coronary artery has plaque that's ruptured, and that triggers platelet aggregation and thrombus formation, so clots. It can also trigger something called vasospasms, so that blood vessel kind of spasms due to the stress, and that can cause something called Prinzmetal angina, and I'll spell it for you. It's Pritzmetal. And with unstable angina, they're probably going to have a negative troponin as well. So then we get to the non-STEMI. That is an intermittent occlusive thrombus. So a portion of the heart wall is infarcted, but the EKG may not show damage yet, but we will have a positive troponin. So there's damage, but it's not all the way through the heart wall. Then, if it progresses, we get to a STEMI, and that's an occlusive thrombus. It is a full thickness wall infarction, meaning the whole wall is compromised. The EKG is going to show that with that ST elevation, and you're going to have a positive troponin. So with all of these, you're going to have chest pain. Most commonly, it's described as substernal chest pain. Your patients could be diaphoretic, sweating. They could have pallor, palpitations. They could experience dizziness and syncope. They could have tachycardia. hypertension, or complain of digestive disturbances. All of those are very common. So this slide, again, just compares stable angina versus acute coronary syndrome. So really, the risk assessment is a nice thing to focus on because how we are going to assess the patient is different based on whether it's stable angina versus an acute problem. Let's see. So basically with stable angina, your patient complains of chest discomfort, and it should be chest discomfort like what they felt before. Usually occurs with moderate to prolonged exertion, and it's in a pattern that's familiar to the patient. The symptoms, the duration, the intensity stays the same. Commonly, these patients will be prescribed sublingual nitroglycerin to take for their chest pain. And what a routine order for sublingual nitroglycerin looks like is 0.4 milligrams sublingually, Q 5 minutes times 3. So what that means is your patient should sit or lie down and take their first dose of nitro. If they're in the hospital, we're also going to assess blood pressure and pulse, respiratory rate, oxygen, because we know that nitroglycerin is going to lower their blood pressure. We also know lowering your blood pressure could cause some orthostatic hypotension, and that's why we want patients to be sitting or lying when they take sublingual nitroglycerin. And so they take the first one, they wait 5 minutes. Are they pain-free? If they're pain-free, that's fine, they stop. If they still have pain, they can take a second one. And if we're in the hospital and we give them a second one, again, we're going to assess vital signs. We're going to keep them lying or sitting. And then they take that second one, and then we wait 5 minutes. Is their pain better? Is it gone? Or is it persisting? If it's persisting, after that additional 5 minutes, we can give them that third dose of sublingual nitro. And that's where we need to stop. And that's where it's important to do your assessment because with each sublingual nitro, it starts working very quickly and it's going to work to lower blood pressure. So we need to make sure their blood pressure is high enough that they can tolerate getting all 3 doses. So it is a priority to call the physician if any patient has chest pain that is not relieved by the 3 nitros because something more may be happening. We may need to take this patient to the cardiac catheterization lab. The other thing about nitroglycerin that we want to educate our patients is that it is dispensed in a dark colored glass bottle and they should store it in that container. It has a short shelf life and it's also sensitive to light. So we need to keep it in a good container. Let's see. So anytime a patient has chest pain, a big thing to ask them is if they have pain at rest, because that is a characteristic of unstable angina. If your patient presents, and this is chest pain, it's unstable chest pain, it's new chest pain, expect the physician to order troponin markers. Troponins, as I've previously mentioned, are specific to the heart muscle and are released with heart muscle damage. So it takes time for those troponin levels to go up. And what happens is when the heart muscle is damaged, such as with a heart attack, troponins leak out of the myocardial cells and enter the bloodstream. And so increased troponin levels indicate myocardial infarction or injury. And those levels can take anywhere from 2 to 6 hours to start to be elevated, and to actually peak, it could take longer. So usually physicians will do a series of 3 troponins 6 hours apart. And just keep in mind that it is possible for people to have a silent heart attack. And with them, they may have like the cold, clammy skin, the dizziness, and not have chest pain. So keep in mind it's a constellation of symptoms, and people can present with atypical symptoms, and we still have to worry about, okay, what's the worst possible thing that these symptoms could represent. So let's talk a little bit more about symptoms. So we've talked about angina, we've talked about myocardial. Um, on this slide is a lot of the common descriptors patient are going to tell you they feel um, when they are experiencing these conditions. So pressure, a squeezing, it could be in their chest, jaw, neck, arm. Um, you could have a feeling of impending doom, like something is really wrong and I don't know what. They could be pale, have cool, clammy skin. Their heart rate could be high. Their BP could be high, it could be low. They could seem very anxious. They could have some GI distress. They could be diaphoretic. They could have shortness in breath. Um, so we want to assess for all the symptoms, not just the classic ones. And a lot of times people will have warning symptoms weeks, days, hours in advance, but they're vague and people don't know what to contribute them to. Um, and just keep in mind that all of this ties back to a decreased blood flow to the cardiac muscle. Okay? And that brings us to, okay, what do we need to assess? All right, we suspect this patient might be having a heart attack. What do I need to look at? Okay, well, we need to get a good pain assessment. What were they doing when it brought on? What does it feel like? Does it stay in one place? Does it radiate? How severe is this? Is this more severe than what it usually is? And timing, how long has it lasted? We're also going to get a set of vital signs. We want to look at that EKG strip, and what we're looking for are ST segment changes, ST elevation, ST depression, or a T wave inversion. We want to look for the QRS, the PRI, and very importantly, we want to ensure these patients are perfusing. So their heart is beating. Are they getting adequate blood flow to their body? So looking at the color and the temperature of their skin, looking at their cap refill, looking for edema. What is their pulse quality? What are their heart sounds like? We want to match the clinical presentation to the lab values. We don't want to only look at lab values. This slide, some people just like to have more information. These are all the different changes that can happen on an EKG depending on what blood vessel, what coronary artery the clot is in. So just some additional information. So, like I said, we want to correlate the patient's presentation with the lab value. Well, what lab values should we be looking at? We should be looking at troponins. You have troponin I and troponin T. These are the most specific labs that can see and evaluate the degree of cardiac muscle damage. It can help determine cardiac from non-cardiac evaluation of chest pain. It can help estimate the size and severity of a heart attack. So like I said, it takes 2 to 3 hours for you to see the injury. So, and then it doesn't peak until, hours later. So that's why we typically do a series of 3, 6 hours apart. So next we've got the CK, which is the creatine kinase. That can reliably indicate an acute heart attack. Myoglobin, you can see increased levels with a heart attack or with seizures. Sodium, if it's too low, we can see tachycardia, low blood pressure, or hypertension. If it's too high, they can have a weak, thready pulse and tachycardia. Potassium, if it's too low, we can see some flat T waves, some ST depression, or even ventricular arrhythmias. If it's too high, we can see peaked T waves, wide QRSs. You can even see asystole. Calcium, if it's low, we could see increased QTI or QT interval. We can see dysrhythmias, irregular pulses. If it's too high, we can see a decreased QT interval and hypertension. And then lastly, magnesium. If it's too low, we can see ventricular arrhythmias or cardiac irritability. If it's too high, we can see wide PRIs, QTs, and QRSs. So keep in mind that these are important lab values to know what the normals are, and then just have a general idea of what you can see when they go outside of the normal ranges. And the reason why we want to look at them is because electrolytes like this are critically important to electrical conduction of the heart. So when we see them outside of the normal range, we can see that reflected in the EKG in different ways. Okay, so this is just a great big picture of the degree of damage, the sequence of events, and the lab values that correlate with it. So it's just kind of a cool picture to check out. Um, so, okay. Oh no, this patient is having a heart attack. What are we going to do? What's our quick treatment? So there's the old MONA acronym. It's a cluster of 4 different things that are first line treatments. And many places that you work at are going to have, especially if you're in the hospital, are going to have MET teams or quick treatment standard protocols, so you know what you can give without a physician order being ordered specifically for that patient. So what are we going to do? Well, we should expect to give supplemental oxygen if their SpO2 is low. We expect to get an EKG as fast as humanly possible. We're going to expect to draw labs, specifically a troponin and a CKMB. We're going to expect to give morphine because it helps relieve pain and anxiety and decreases oxygen consumption. We expect to give aspirin and Plavix because they both inhibit platelet aggregation, which again will help decrease the clotting. We are going to expect these patients are going to be given heparin because again, it's going to inhibit that clotting cascade. We're going to closely monitor renal function and probably watch those renal labs too to make sure that they're getting enough cardiac output to perfuse the kidneys. We are going to give beta blockers and calcium channel blockers. Those block the sympathetic nervous system, and that's what gets all revved up when there's something going wrong in the body. Think of it as the gas. So when you give it more gas, you're going to go faster. So beta blockers and calcium channel blockers block that, slowing things down. Okay, and then we're also going to do something to block the renin, angiotensin, aldosterone system. And you think of that system as our body's clamp down and constrict response. So, oh my God, something's wrong. We got to clamp it down. Well, we're going to block that with an ACE inhibitor or an ARB so that things vasodilatate and we get better blood flow. So some reminders for you back into farm. Beta blockers, those help relax your heart muscle, slow your heartbeat, decrease blood pressure, which makes the heart's job to pump easier. They can also help limit the amount of heart muscle damaged and prevent future heart attacks. Remember that there are cardioselective and non-cardioselective beta blockers. So beta 1 is the heart, beta 2 is the lungs because we have two lungs. If it is non-cardioselective, remember it's going to affect the heart and the lungs. And non-cardioselective beta blockers should not be given to people with asthma, and it's not a good idea for people with COPD as a general rule. If your patient doesn't have asthma, doesn't have COPD, we're still going to monitor them for wheezes or bronchospasms because it is a potential adverse effect from a non-cardioselective beta blocker. That's something very important to remember. Um, Also remember, I touched base on the renin-angiotensin-aldosterone system. We're going to be looking for urine output. The bare minimum urine output is 0.5 milligrams per kilogram per hour. Ideally, it should be 1 milliliter per kilogram per hour. Just to review on calcium channel blockers, those prevent calcium from entering the cells of the heart and the blood vessel walls, which result in lower blood pressure. They help relax and widen those blood vessels. Some of them can actually slow the heart rate too, and help control chest pain and help with irregular heartbeats. But remember to change position slowly. And then that brings us to our end goal. What are we wanting to happen? Reperfusion. Open up that occluded blood vessel so blood can flow through there normally. So nitroglycerin. I've talked sublingual. Now I'm talking IV. We can give them an IV infusion of nitroglycerin that helps dilate those coronary arteries and veins, and that can stabilize the blood pressure and reduce the amount of pressure on the right side of the heart. Thrombolytics, those are our clot busters. They help dissolve a clot that's blocking flow to the heart. The earlier we get that on board, the greater chance of survival and less heart damage. And then we can go to the cardiac cath lab, and we can use TPA, we can use percutaneous interventions like balloons or angioplasty, or we can send them to the operating room to get a CABG, which is a coronary artery bypass graft, which I talk more in our other PowerPoint presentation. So that brings us to the end of this recording. Thank you so much for listening, and please just email me if you have any questions.